11 bodily systems, going from the cardiovascular system to the immune system to the endocrine system, and I think this is a multi-system disease, and you can either talk about therapy or whatever, but I would rather concentrate on a system and systemize the questions around this system. I mean, if we start, like for example, with the immune system, like I explained today, we see a reduction in Th1, we see alterations in Th1, Th2 ratio, and increased Th17. What does that mean, for example? So I would like to open the discussion there, whether people want to know more about this, or whether there's a point of discussion. There are three main of the 11 bodily systems. The three main that are affected is the neurological system, the digestive system, and the immune system. And so I suggest we start with the immune system and ask questions about the immune system, then go to the other bodily systems, because it's a disease that's not very well known.
Can I ask about in the immune system, do you see many patients with ME who have like low IgG subgroups and low levels of B cells?
Yeah, we have 5% or so, 5%, but these are usually people that have been sick for a very long time,
okay,
and have defective B cells. We have our idea what the cause is. I don't think it's kind of an exhaustion, but low IgG is not always synonymous of low B cells. Because I do an immunophenotyping in all my patients, I have numbers of B cells, and it's a very, very low percentage of people that have low B cells. It's less than 1%. But IgG3 deficiency is present in about 4 to 5% of ME patients.
So would you classify that as a particular subgroup of people with ME, or do you just think that's a worser end of the scale?
I think it's something that comes with time. All the patients that are ill less than 2 years, they have high lymphocytes, they are lymphocytic, and they have B and T cells that are increased even instead of low numbers or low normal numbers. But extremely low numbers of B cells we don't see, and we have 3% of patients. If we talk about B cells, we have to talk about T cells too. We have about 3 to 5% of patients that have lower numbers than normal of T4 cells, and 20% has lower than normal T8 cells, CD8 cells. So the CD8, the low CD8 cells, is about 1/5 of the patients, and 1 out of 20 has like 8s, and then they're like 300 or 400 CD4 positive cells, and a few have only 100, or I have with 75, which when they come into the hospital they say, no, you have AIDS, and have the same numbers as the AIDS patients.
So in terms of, because there's the literature on sort of like the immunological deficits seem quite sort of discrepant. Some find low, some find high. I mean, is that because essentially the patients are mixed in the ones that are ill for a short period of time, or the patients for a long period of time, so you just end up with
what co-infections they get in the meantime, what toxins they are exposed to. Mycotoxin has a specific effect on the system. And then I think the herbs also play a role. I think we have to learn that new thing in ME, because it's a lot talked about in MS, in rheumatoid arthritis, and ME is just another autoimmune disease. And I think what these herbs do, they activate herpes viruses. They are the bodies of the herpes viruses, and so the reaction of herpes viruses also induces immune changes, and can cause B and T cell changes, and other autoimmune reactions. So I think we have to progressively bring that into the science of FME CFS. We're not the only ones. Some people in the US are now looking in the blood, and they're finding all sorts of herbs.
You talk about it's a multi-etiological disease, but is there any chance of getting some specific biomarker for this disease?
I mean, as I told earlier, there are about 5, 6 different things that are good biomarkers, and I think we have to make a panel. So you have to make a panel where you can predict if you see the blood that there's 95% chance that this is an ME patient. If you take the results of somebody, you should be able to say with 95% certainty that this is an ME patient.
Because it's very hard for doctors. Last week I had a patient, I thought he had ME or probably hypochondriac. He had a tumor.
Yeah.
So
yeah, that's right. That's right. And with a tumor, you're not going to have a low CD57. There's no reason to have a low CD57. So this is one of the parameters I use. You're not going to have high hydrogen sulfide in your urine if you have just cancer. So you need, I think there's right now 5 different tests that you can use, plus a urine test, which gives you a high, but at this moment we are calculating, Dr. Danny Komans, who is a professor of statistics at James Cook University and in Brussels, he has new techniques of making decision pathways. So medical decision, and medical decision is used on statistics. So you take 100 variables and you take out those who are most predictive for the disease. So, but for that you need a mass of data. You need data of 2,000 people, and you put them in the statistical program, and you suck out those things that are the most predictive, and then you add them, and you increase the prediction based on that. And maybe one of those parameters will just drop out because it is only predicted for 50%, while the others have a higher predictability. So it's a decision tree that you make. You start then with a parameter that is the highest predictability, and you go progressively down, and at a certain moment you cut off because of economic reasons. You don't want, we're not able to measure everything. But what we want to do is within 1 year give GPs the possibility to measure maybe 4 parameters and get them a high predictability that this is a ME patient without seeing the patient.
Without seeing it.
Yeah, without. You should be able to on a number of parameters predict that this is an ME patient. But as I say, you have to put in a lot of controls, and that's the problem.
And it's a lot of work.
It's a lot of work to put in the controls and find good controls, because people say they have some solidarity, but if you go to some tennis club and you ask 100 people to give blood, maybe 5 want to give blood.
So with these biomarkers that you're thinking of, would you be able to get those tests done on your patient in your country?
Well, what happens to a usual patient with ME? I have to figure out, is this a psychiatric patient? Is there some underlying disease, real disease? And some just don't make sense, like last week's patient. It didn't make any sense.
Yeah.
Tingling sensations, like feel weak and this and that. Could it be the shampoo? Could it be the aluminium in the shampoo? It didn't make any sense. A neurological exam that didn't make any sense. But he had a tumor.
But would you, in your country,
if
be
I had
able to do these?
some exam, like he said, it wouldn't save me time and money.
But would you be allowed to do that by your authority?
It will be published, you know.
But,
published.
Do you have like?
But it's nothing there, because we're looking about 16 infections, just Bartonella, and looking for Lyme's disease.
But let's wind forward. I just want to find out if we've got these biomarkers. Do the guidelines in your health system allow you
because we have to
do those tests on patients?
We exclude rheumatic disease, a neurological infection. You can exclude MS with MRI. You can do a lot of things.
You can use these tests also in a negative way, you know, to exclude. You can say they're predictive of, but at the same time they exclude other diseases.
Yeah. But for example, GPs in the UK couldn't do those tests because they're not in the NICE guidelines.
Probably not, yes.
But you can in your country.
But this is politics, it's not
politics.
science.
Yes, I'm just trying to
For example, homework was really great, you know, using a pedometer to just to objectify chronic fatigue syndrome.
And that's so important for the patients because they've seen things like the PACE trial being published in a very prestigious journal, The Lancet, and they used actimeters. They assessed all their patients beginning with actimeters, did the psychosocial interventions, and then didn't assess them at the end. So that was the only real objective measure, and they didn't follow that up. And patients, you know, and I think there was about 8 or 10 letters from patient charity organisations. They were really, you know, writing to the Lancet, and they actually published a lot of these letters. It's just, you know, it's so frustrating. You know, if you're trying to persuade the patients and their doctors that 30% of people recovered using psychosocial interventions, then they really have to show it.
GPs with patients like you is that they leave us because they get frustrated. Because we exclude that you don't have something fatal. And then we say, well, you have to live with it, or try antidepressants. Try this.
But I think the try antidepressants route is frustrating for patients because, like I showed in the presentation, emotional well-being is actually their strength.
Yeah, but doctors were not very good at it.
I think that's,
we have to come to a positive diagnosis, you know. That's why the Canadian criteria for me, they are for GPs, not for people like me, because the GPs refer to me, and you use those Canadian criteria, and they're not very many biological things in there, but they give some sort of a framework, and then there's already a high chance that this person has ME when he fits those criteria. And then the next level should be that the GP has a small panel of blood tests to absolutely confirm that, and then sends them even more well referred to a specialist, who then comes with a positive diagnosis and goes look for all the infections and so on, and finds out in which stage of the disease the person is. Because that's what I'm doing every day. I'm looking at the stage of the disease. People are all well referred. I mean, we almost never find other pathology because they're all well referred now.
And that's a real contrast to the UK, where they use this Fukuda criteria, because 40% of people that get referred to the CFS service in Newcastle, 40% had other conditions, and most of those were other treatable conditions, whether they're sleep disorders, psychiatric disorders, and things. And you would, you know, and the Canadian criteria, I don't know if you've seen it. Have you got a copy of that? We can make sure you get a copy, because it clearly shows in that the differences in symptoms between sort of things like major depression and ME. So those kind of things can be used as a really quick guide for you too.
But again, we can turn this around. You know, if we go now to look in all the psychiatric hospitals in England, we will get out 50% of people with ME or infections. Because a lot of people with Bartonella and Lyme get into psychiatry and never get out. One of my colleagues, he was 25 years old, he did his last exam as a doctor, he wanted to start his practice, he got flu-like illness in June, got hospitalized in August, and 20 years later he was still in psychiatric hospitals. He had done 6 hospitals, had no more house, no family, nothing, and he didn't have money to get treated.